Thanks everyone for coming to IRP series. Today is one of our affiliate seminar series. We're always excited when we have folks elsewhere on campus doing amazing work, and today you get to meet one of them. So we have Kevin Look, who's coming to us from pharmacy, and we'll be talking about his work on senior care and Medicaid drug coverage. He's asked to take questions of clarification, but hold those hard-hitting substantive ones till the end. Kevin, we're delighted to have you here. Thank you.
Yeah, thanks for having me. So my name is Kevin Look. I'm an associate professor, and I'm also the chair of the Social and Administrative Sciences Division over at the School of Pharmacy. I've been doing work with IRP for a number of years now, but I'm also an affiliate here. So today I'm very pleased to be talking to you about some work that I've been involved in for the past 7 or 8 years or so, doing some collaborative work with the state of Wisconsin's Department of Health Services. So I've been leading an evaluation of what is known as the Wisconsin Senior Care Program. So just to give you some background on the program that we're talking about today, this is a prescription drug assistance program for low-income seniors. It's been in effect for about 22 years or so now. So it's an established program that's been operating with fairly minimal changes for the past 20 years. So it's a fairly stable program as well, which is nice. I'll talk about some recent changes that have been happening to the program to expand some of the coverage that it is. But essentially what this is it's a program that offers drug insurance coverage, solely drug insurance coverage. It does not provide any sort of medical benefit. It does not provide coverage for any other sorts of healthcare services. So as a result, a lot of these individuals, these older adults who are enrolled in the senior care program also are enrolled in the federal Medicare program for older adults, which is where they receive their health services and other types of health services that they need. Now, prior to 2006, we recognized as a country that older adults were really struggling to afford their medications. Depending on who you ask and the numbers that you look at, anywhere between 25 to 50% of older adults struggled to afford their medications. And so a lot of states created programs like this. The state drug assistance programs might be another name you might have heard of, to basically subsidize the costs of prescription drugs for older adults. In 2006, if you know your Medicare history, this was the year that Medicare Part D was created. So Medicare Part A is the one that provides coverage for things like hospital services or inpatient services. Part B is the one that covers services you receive from a provider, like a physician, a nurse practitioner, a physician assistant, usually in like a clinic or an office setting. And they created Medicare Part D for drugs. And so this was a federal opportunity for older adults across the country to enroll in and receive lower cost drug insurance coverage. Because the federal government created this Medicare Part D program, most states got rid of their state drug assistance programs or really scaled them back. And as a result, senior care is a little bit unique and a little bit interesting from that aspect, because it's continued to stick around in part because of how generous the coverage is, how user-friendly it is, and how popular it is, both at the legislature as well as among other adults who are enrolled in this program. I think Pennsylvania has a program called PACE, which is kind of the other big state drug assistance program that still exists. So I think there's 1 or 2 other ones that provide very little coverage, but senior care is a little bit unique. So that gives us sort of a unique research opportunity here in the state of Wisconsin as well. Now, this is a program that's housed within the Wisconsin Medicaid program. It's administered by the Wisconsin Department of Health Services, or DHS. And it's partially funded by what's known as a CMS Section 1115 waiver. Are any of you guys familiar with those? Has Dr. Burns come and talked about managed care evaluation? Because she will give you sort of the same spiel. But so these Section 1115 waivers essentially give state Medicaid programs, which are primarily intended to provide comprehensive coverage for low-income individuals in each state. It gives them flexibility to design and test different ways or improve their Medicaid programs. So what this does is it allows states to receive money from the federal government to provide insurance coverage or other benefits for low-income individuals in the state or needy individuals in the state, but you don't have to offer sort of the traditional full Medicaid package. So really when people talk about Medicaid They're talking about coverage for health services, nursing home care, prescription drugs, pretty much anything you could think of. And usually there's very little or almost no out-of-pocket costs. I'll show you how the senior care program is a little bit different in terms of what they cover and things like that. But the big one being it only prescription drugs. So you can already see they've changed sort of what the covered services are. There's a lot of other examples here in the state of Wisconsin and nationwide of programs that operate under these waivers. But again, the key idea to take away is that it provides some flexibility for states to offer programs like this. And the current waiver period, this was one of the first ones to be approved for a 10-year period. So again, it provides some really nice stability, not only for the states in terms of knowing that this program will stay in effect for the next 10 years, or I guess at this point we're in 2024, so maybe for the next 4 or 5 years until that comes up for renewal. But it also provides the older adults who are enrolled in this program some sense of stability, that they know this program's not going to just disappear tomorrow. So the waiver that they've received does not cover the entire senior care population, and I'll show you what I mean in just a minute. But what it does is essentially CMS, the Center for Medicare and Medicaid Services, is providing money to support the needs of the lowest income members who are enrolled in this program. So about half of the senior care population, a little bit under half. So hopefully as I go through some of these things will make a little bit more sense if you're not very familiar. Yeah, please.
But it's available for everybody.
It is available for everybody, and I'll give you some more concrete. I'll show you a table that I think will provide a little bit more context for that. So anyone who's an older adult in Wisconsin, 65 or older, can enroll. The people who are in the lowest income buckets are sort of funded administratively through this waiver. The other half are not. They're covered entirely by the state. So again, it makes the program more affordable for the state to offer instead of them having to restrict that only to certain populations. So those state dollars go a little bit further. So shown here are the goals for the senior care program. So these are the goals that are stated by the Wisconsin Department of Health Services for this program. And I'm going to point these out because I'm going to link these to when I start talking about the evaluation that we're conducting and the research that we're doing, because I think they're linked pretty closely with these program goals. So what they're hoping to do with the senior care program first is to keep Wisconsin seniors healthy, right? And the second is to reduce the rate of increase in the use of non-pharmacy related services. That's kind of a weird statement, but to translate this, what numbers 1 and 2 are saying is we know that prescription drugs can be a cost-effective way to care for a lot of chronic conditions. They're often significantly cheaper than a lot of medical services, right? If you end up in the hospital, if you end up in the emergency department, we're talking serious money here. Whereas certainly some prescription drugs, as you see in the news, come with very significant price tags. But generally speaking, prescription drugs are a very cost-effective way to manage someone's health and keep them out of those other settings. Finally, the third goal is to help control the overall costs for the aged Medicaid population by preventing or delaying seniors from becoming eligible for Medicaid. So again, the idea is by keeping people healthy, by reducing how much they have to pay for prescription drugs, you're not only protecting their health, but you're also protecting their finances. And so you're keeping them from sort of getting to the point where they become eligible for that full Medicaid benefit, which comes with significantly increased costs from a state's perspective. So they're sort of viewing this as a way to keep people from ending up in either really sick health state where they end up eligible for Medicaid for that reason, or they just, sort of reduce their income or assets to the point where they become fully eligible. From a coverage perspective, senior care actually covers the same set of prescription drugs as the Wisconsin Medicaid program for the waiver group, which is really nice because there's a lot of consistency between these programs. So they cover the same drugs, they use the same preferred drug list, or PDL, which is another name for like a drug formulary, the list of drugs that are covered. That also gives the states a better ability to negotiate the prices for those drugs and results in cost savings and things like that. So they're sort of using the same set of covered drugs and now just applying them to this new population. I mentioned that there haven't been a lot of changes to this benefit. Certainly with the pandemic coming and increases in things like COVID testing and COVID vaccinations, that became an area of increased interest. And as a result, SeniorCare began covering those services during the pandemic. And then in 2022, they began covering all recommended vaccines for older adults. Now, the caveat is this covers all vaccines for older adults that are received at a pharmacy, typically from a pharmacist or a technician or someone like that. If you go to your physician's office or your clinic to get a vaccine, that's covered through your medical benefits. So for these individuals, that would likely be their Medicare coverage. Their expansion to cover vaccines, I'll talk a little bit more about how effective that's been in the past year and a half or 2 years or so. But this mirrors what is happening at the federal level, where they expanded coverage through all the Medicare Part D, again, prescription drug insurance plans, and they cover the same drugs. And recently there were changes, I believe it was through the IRA. I can't remember if it was this year or if you remember, Rebecca, if it was this year or last year, but they removed cost sharing for all vaccines as well as a way to promote public health. So the previous question had to do with who's eligible for the program. Essentially, nearly all Wisconsin older adults are eligible, regardless of your income. Really, the main criterion is that you're 65 or older and you live in the state of Wisconsin. There's some basic citizenship and residency requirements, but they're typically not a major barrier for most older adults. The only group who is excluded from coverage are those individuals who are already enrolled and receiving full Medicaid benefits, because again, you can't be in multiple programs that do essentially the same. Now, this program is very comprehensive when it comes to prescription drug insurance coverage, and I'll show you some more details of that. But it's considered what's known as creditable coverage by the Medicare program. If you have done anything with Medicare Part D or Medicare, there's this weird thing where you have to enroll in a Part D plan if you're a Medicare beneficiary. If you don't, you have to pay a penalty unless you have what's known as creditable coverage. What this really means is that SeniorCare coverage is at least as good as Medicare Part D coverage, and actually, I'll show you some examples of how it's actually more generous. And again, I think that's part of the goal of the program is to help support the health and the financial well-being of older adults here in Wisconsin. It's also not an all or nothing deal. You can enroll in other insurance plans as long as it's not full Medicaid. So what we're seeing, and I'll show you some evidence of this from the analyses that we were doing, is increasingly we're seeing SeniorCare being used as supplemental coverage. So a lot of these older adults are starting to enroll in Medicare Part D plans, especially because because of this penalty that looms over you if you don't enroll. A lot of seniors are choosing to enroll in Medicare Part D plans, but your copays may still be $50, $100, $500, depending on the medication. So a lot of these individuals are enrolling in SeniorCare, who now takes your copay and essentially pays the majority of it on your behalf. So you can have multiple sources of insurance coverage. Some people also have insurance coverage from like a current or former employer, right? A lot more people are working beyond age 65, or maybe they have some sort of retirement benefits that provides insurance coverage. And again, SeniorCare can be combined with that, again, as a way to save that individual. So this is an example of showing how how your income affects what your benefits are in this program. So the top two groups, level 1 and level 2A, these are those individuals who are covered by this CMS section 1115 waiver. Essentially, the state is receiving federal money to help support offering this program to these individuals. And you can see that the income for those groups goes up to about 200% of the federal poverty level. Those individuals in level 1, so your income is 160% or less of the federal poverty level, you have no sort of deductible or any sort of amount that you need to pay up front. You essentially just have a $5 copay for a generic drug or $15 for a brand name drug, which are typically more expensive, which is why their copays are typically significantly higher. If your income is in that 160 to 200% of federal poverty level, they introduce this $500 deductible. So the deductible is the amount you pay out of pocket before your insurance kicks in. So these individuals have to pay the first $500 of their drug costs. After that, they just have that $5 and $15 copay. That's a very typical structure for most insurance plans, especially Medicare Part D plans, where typically there's some deductible or out-of-pocket amount you pay up front before your insurance starts paying anything. Although the size of the deductible will vary. Yeah,
$500 per calendar year or
per
500
calendar year. Yes, per calendar year. So depending on the drugs that you're taking, that may be one drug.
Yeah.
That could be an entire year's worth of drug spending, right? If you're getting a drug that costs $5 a month and you're only on one or two drugs, you may never actually hit that deductible. But if you're taking a drug that costs $1,000, you'll hit that in January, and then you don't have to worry about that amount until the following year. Yeah.
This, you may not know this, but off the top of your head, do you know on average how much people over 765 would spend? I'm
It's typically much higher than that.
okay. Thank you.
Can't give you an exact dollar amount, but it's typically much higher.
Okay.
And even the sort of standard Medicare Part D deductible is fairly similar to this, a little bit higher depending on the year because they kind of increase things as they go on. So if your income is above 200% of the poverty level, up to infinity, I suppose, you can still enroll in the program. You're just now not part of that waiver group. So I'm going to refer to these people as the non-waiver population, mainly because they're kind of a nice comparison group for some of our analyses, right? They're in the same program. Really, the main difference between the two is that they have higher income. And that comes with some slight differences as well. But you see, depending on what your actual income is, the deductible gets a little bit larger. If your income is much higher, so 240% of the federal poverty level or higher, there's what's known as a spend down, which means you have to pay a certain dollar amount before you even get to that deductible stage. So people who do have higher income can still enroll in the program, but they have to spend more money to use the benefits. So there is sort of this declining return. It really is designed mainly to support the lowest income populations. Yeah.
So for retired people, what's counted as income?
That is a great question. So let's transition to my next slide. Checks in the mail. So this is a really affordable drug plan. As I mentioned, the out-of-pocket costs just for the copays and even some of the deductibles are often again, similar to or less than what many seniors are paying to enroll in Medicare Part D, which is the primary source of insurance coverage for most older adults in Wisconsin who essentially aren't in this program. And that annual program enrollment, so you enroll once a year, you can enroll at any time. So technically, it may not be a calendar year, it may be an enrollment year. So if you enroll March 1st, your deductible will reset the following March 1st. So it's a little bit off in that respect. But you have stable coverage. And the interesting thing about this program is there's a $30 enrollment fee. That's it. $30. You don't pay a monthly premium. So the average Part D monthly premium was $55.50 in 2024, this year. So you don't have to pay a single cent in the form of a premium. So this right off the bat, it can save an older adult hundreds of dollars, especially depending on how many drugs that they use. It's like that. I mentioned here that there's a simple income screening and no asset test. So if you want to enroll in sort of traditional Medicaid coverage, you have to go through a pretty rigorous review, not only of the income that you earn, whatever the source of that may be, but also the assets that you own, right? You may have little or no income, but if you own some land, you have a farm, things like that, you may not be eligible for Medicaid. However, for this, it's primarily self-reported, either in individual's income or spousal income. And so, that's essentially it. There's not a lot of rigorous testing of this. And so it's very simple, it's very quick. It's like a one-page form that you use to enroll in this, as opposed to the more longer, rigorous process for Medicaid. There's a lot of churn in Medicaid where people, you make a little too much income one month and you drop out of Medicaid because your income is too high and then you lose that job, or maybe you're, part-time work and things like that. So there's a lot more stability in SeniorCare. Once you're in for 12 months. And the application process is very simple, very easy, and very affordable. So as I mentioned, there's a strong history of support for this program among older adults that are enrolled in the program. And that has also translated to strong bipartisan support, which is a little more uncommon these days. So as part of these CMS Section 1115 waivers, they're required to have an independent evaluation. They're not allowed to just do all of the work on their own. And that's really where our research team comes in, because the evaluation is supported through the IRP's Medicaid Evaluation, Research, and Technical Assistance Program, or the MERTA program. Shown here on the slide is sort of the stated definition of what the MERTA program is, right? So it researches the impact of Medicaid policy coverage issues and health program interventions that are initiated by DHS. But how I like to think of this is these are really nice partnerships between the state agencies, Department of Health Services, and UW researchers, faculty, staff, students, postdocs, fellows, and things like that. So it's kind of a win-win for both, because they are able to get that independent evaluation that's required as part of this waiver. And it's also a nice opportunity for us to do some research and look at some things that we find interesting. Do you have a question?
I was just wondering, the costs seem kind of low, like the copays seem pretty low to me. So I was just curious about the, if those are if the state is like doing negotiations for the drug prices.
Yes.
If like overall the spending, like per person differs a lot from like Medicaid Part D.
Yeah, so I'll try to show you a little bit of information on that. I think the full report that we submitted this past year has a lot more detailed information on those sorts of things. But so to answer the first part of the question, yes, the state does negotiate with drug manufacturers for things like discounts and rebates to make the program more affordable. A lot of that is done sort of under the entire umbrella of Medicaid. So it's not like they're negotiating for just SeniorCare separate from Medicaid. It's all kind of lumped together, which is why they use the same list of drugs and things like that. It's a lot more efficient. And also that means they have a larger population they can negotiate on behalf of to get cheaper prices. So that's definitely what happens. And typically, there's a lot of variability in the spending, especially depending on what group you're in. So again, I'll show you some data on that, but sort of the short version is the lower income individuals in the waiver population tend to use the program a lot more than those higher income individuals in the non-waiver population, again, because they have to spend more money to sort of get their coverage to kick in the first place. So it does vary by group. For some of the groups, they're very comparable. For others, SeniorCare is either cheaper or more expensive. So it's not a clear answer, but I'll give you some more hints on that as I go through, and maybe we can talk more about it at the end if I don't directly answer the question. So as I mentioned, the evaluations was developed by us as UW researchers and some of our collaborators as well. We have some external collaborators who've worked with us over the years. This was independently done by us. We have to work with the state in order to get the evaluation design approved and make sure it's meeting their goals and needs as well. But we're the ones who developed the evaluation plan. We're the ones doing all of the results, all the research. And so again, it truly is an independent opportunity for us to do some research. So the results that I'll be talking about today are from one of our interim evaluation reports that was turned in this past year. Because of some of the data lags, it covers only the first 3 to 4 years of the waiver period. That might be a type. So I mentioned the goals of the SeniorCare program earlier on, and I mentioned I'd come back to that when we talk about the evaluation, what we're actually interested in looking at. And I think you'll see some pretty clear linkages between the two. So what we did was we created a series of hypotheses that we were interested in exploring as part of the evaluation. So the first is that SeniorCare will have a positive effect on both member medication use and financial hardship. Again, directly related to those goals of the program to keep older adults healthy and also to make sure they can afford their medications. The second hypothesis is that SeniorCare will have a positive effect on the health outcomes of Wisconsin seniors. We don't want to just offer a benefit. We don't want to see that a drug insurance program is offered. We want to see that it's providing good coverage, it's meeting the needs of individuals, and it's resulting in better health. Again, linking back to that idea of the use of prescription drugs might be a more cost-effective alternative than seeing these individuals using medications incorrectly, unsafely, and ending up in nursing homes, hospitals, emergency department visits, and things like that. And the third is SeniorCare will reduce the likelihood of Medicaid entry and provide savings, cost savings to the Wisconsin Medicaid program. Again, this is that idea of if we can keep seniors healthy, protect their finances, then they won't transition to sort of full Medicaid coverage, which results in significantly more costs from the state's perspective. So underneath each hypothesis, we created a series of research questions. We identified data sources that we would need to use. We identified research methods in sort of accordance with best practices. We also identified certain outcomes or things we were interested in looking at. So just to give you an example of how this works, looking at hypothesis 2, this idea that senior care will have a positive effect on the health outcomes of Wisconsin seniors. Well, what do we mean by health outcomes? Well, our first research question is, how does the quality of medication use in senior care compare to those other older adults who are enrolled in Medicare Part D? And we're focused here on Part D enrollees who live in Wisconsin. The idea that if people weren't enrolled in senior care, the closest counterfactual would be those individuals who are in the Medicare population. Because if senior care went away tomorrow, that's where they would primarily end up. So what do we mean by quality? So we looked at things like medication adherence. Are people taking medications as prescribed? Are they able to afford their medications and consistently take these medications? Particularly focusing on common chronic conditions. So you'll see things like diabetes. Statins are for cholesterol. These renin-angiotensin system antagonists are more for like high blood pressure, cardiovascular health and things like that. So very important that medications are taken consistently to make sure that these conditions. There's also this aspect of medication safety. So looking at the use of high-risk medications, those kinds of medications that have been shown to be unsafe, maybe harmful, increase things like fall risk or potential for addiction or abuse, things like benzodiazepines. There's been a lot over the past couple of years in the federal Medicare program about the use of benzodiazepines and opioids in older adults because it increases fall risk. There's abuse potential and a lot of dangers for older adults. So looking not only at quality, but also at medication safety. In terms of who we're actually, so that's just one of many research questions. There's a lot of other outcomes we looked at for each of our research questions as well. Again, I'm not sure if the report is publicly available yet. There's an older version of the report from the prior evaluation that's available on the IRP website if you're interested in looking at some more examples of what this looks like. But just to give you a sense of the types of populations we looked at in the evaluation, the first one is the one that's pretty much the one that's most of interest, which are those low-income senior care members who are enrolled in the program and are covered by this waiver. So again, I'll refer to them as the waiver population. And then we also have the non-waiver population, which are people enrolled in the same program, but they have slightly higher income, which means on average, they have higher income, certainly, but also their costs are going to be a little bit higher to benefit. We also created matched comparison groups of Wisconsin Medicare Part D beneficiaries. The first being just sort of the general Part D population. This is really the most applicable or the most reflective of the senior care population, sort of typical similar health status, similar use of prescription drugs and things like that. Again, if senior care went away tomorrow, that's where most of the senior care population would fall. Often, I may also refer to this as the non-low income subsidy population. Again, by that I just mean sort of your typical older adult enrolled in Medicare. The second group are those Part D enrollees who receive what's known as the low income subsidy. So these are individuals who do have very low income or assets. Some of these may be dually enrolled in Medicare Part D and state Medicaid program. Typically their health is significantly worse. They have much higher health needs on average. So from an income point, they're a little bit more similar, but from a health perspective, they're quite different. And I'll show you how that came up in our analysis. But that was something that CMS was particularly interested in understanding, not just how do they compare to the general Part D population, but also lower income subsidy individuals. The final comparison group that we had for certain analyses was elderly Wisconsin Medicaid beneficiaries. I don't like using the term elderly as much because it's kind of out of style in the health sciences, but I use that specifically because we refer to this as the EBD population, elderly, blind, and disabled. And so we just took the E population out of that. We excluded individuals who were blind or disabled because again, they have very specific health needs. They're not sort of reflective of the typical senior population. And the way we use these individuals primarily was to look at senior care members transition from the senior care program to receiving full Medicaid benefits. Again, sort of an idea that the senior care program would not be meeting its goals of keeping those individuals healthy and keeping them out of that program. We also use them for some analyses related to like Medicaid funded nursing home use. Yeah.
What proportion of people eligible for senior care are getting senior care? Those other two groups, right, could all be getting senior care.
Correct. The enrollment size of senior care is, I have some concrete numbers a little bit later. So instead of guessing or skipping ahead, I'll come back to that in like 2 slides.
Okay.
But it is significantly smaller. The senior care program is much smaller. And there are some people, like I said, who are enrolled in both programs, which kind of makes it a little trickier as well. But you know, we're talking like a 3-to-1 ratio. About 25% of people on senior care and the other 70%. Hopefully my numbers support that. Get a guess.
What's funny about kind of the crosstabs between these kind of different groups, because you mentioned that in senior care, the income test is self-reported and much less rigorous. Do you find that there's some people who are low income Section 1115 waiver senior care members, but not low income subsidy, which could either mean that they're lying or that they don't want to jump through the hoops to get?
That's an excellent question. We have not been able to look at that in much detail, in part because of really limited sample sizes. We were actually really excited to do that analysis. And given how many subgroups of low income subsidy people there are, they get really small really fast. I don't know if I have a lot of low income subsidy results in this presentation. Again, in the full report, we have a lot more, so I'm happy to talk to you more. But that population, there's not as much, which again, I think is why the non-LAS population, that first group, is really more reflective of sort of the typical population. So I mentioned not only do we have certain populations we want to look at, but we also have a rich variety of data that we're using for this. And some of this is actually quite unique. And given some of the changes that are happening at CMS may not be possible in the future. So we're going to have to pivot and figure out how we're going to do this in the near future. So one of the primary sources of data that we use are senior care enrollment and claims data that we get from the Wisconsin Department of Health. So again, this is one of those really nice things of having these joint partnerships between state agencies and researchers here at UW through the MRTA program, is that they're able to facilitate getting access to these data since they're stored here at IRP. So when we talk about senior care data, we certainly have prescription drug claims data. I also mentioned earlier the vaccines that are now covered as of 2022. One type of data I'm not going to spend a whole lot of time talking about, in part because it's so rare that there's not really anything to talk about, are medication therapy management services. This is an essential benefit that's required through Medicare Part D programs. So individuals who are taking a certain number of drugs, who have a certain amount of drug spending, et cetera, are required to receive these services. What they are essentially a pharmacist doing a comprehensive review of your medications and making recommendations to see, are there potential ways we could save you money? Could we find more effective drugs? Are there potential drug problems that we could solve? Or are there actual side effects or things that need to be addressed, safety issues? But unfortunately, it's so rare in the senior care population, even though this service is covered. I've just kind of decided to skim over it today, but I'll come back to that very briefly at the end. We also have access to Wisconsin Medicaid eligibility and claims data. Again, we used some of the data on the EBD, the elderly, blind, and disabled population, primarily the elderly population, to look at certain outcomes. So we do have their prescription drug claims as well. We have nursing home claims, again, to look at things like Medicaid paid or Medicaid funded nursing home claims. We have their health claims. So anytime they go to see a doctor, get admitted to an ER or a hospital, we have those sorts of claims, et cetera. And then we also got data from the federal Centers for Medicaid and Medicare Services, known as the CCW, or the Chronic Conditions Warehouse. And so we have 100% sample of Wisconsin Medicare beneficiaries. So what that means is we have data on every single Medicare beneficiary in the state of Wisconsin, which is a really powerful data source that allows us to do a lot of subgroup analyses to make very good comparisons and identify matched samples and things like that. Use those fun advanced statistical techniques that we learn in all the classes we take in graduate school, right? And do some really cool stuff. In addition to that, we also have a 5% national sample. I think the best analogy is comparing SeniorCare to Wisconsin Medicare beneficiaries, but also sometimes that may raise questions about, well, how do we compare to the rest of the country? So we do have that ability to look at sort of the national Medicare program as well. And the really cool thing is that we were able to link these data sources. So we can identify, I mentioned the fact that for SeniorCare members, SeniorCare only covers their drugs. They have Medicare for everything else. Well, we had to use social security number. We had to go through a bunch of security and permissions and things like that. But we are able to identify all the SeniorCare members in the Medicare population. So now we can actually see both their drug claims and their medical, which is very, very challenging to set up. It's very rare to see this happen, not just from a security issue, but from a practical issue. These data are very, very expensive, typically somewhere in the $70,000 a year range. You can see we have 6 years of data with about 4.3 million Medicare beneficiaries per year in our comparison group. So we're talking a lot of data. And apologies to the IRP staff who have to find places to shove all of our data in servers and constantly tell us, stop using so much space, right? The primary group that we focused on are individuals who are enrolled in what's known as standalone Medicare. So I mentioned A covers hospital, B covers like physician services or outpatient visits, and D covers prescription drugs. If you're enrolled in those three programs, you're sort of a standalone Medicare beneficiary. You have coverage that's the same across the entire country, and things are very standardized. And also they have complete claims for them. There are about, it depends on the state, but about half of Medicare beneficiaries are enrolled in what's known as a Part C plan. You may have noticed one of the letters is missing. These are also known as Medicare Advantage plans. These are managed care plans that are offered by private companies. So here in Madison, I believe Quartz has plans like that. SSM Health, the Dean Health Plan, whatever their name is these days, has plans like that, Group Health and so on. So they're offered by private companies, which means those data also belong to those private companies. So even though some of the Part C managed care data appears in our claims, we don't have complete information on them. And so this isn't a limitation of our study. This is just a limitation of working with Medicare data. Typically, we focus on sort of this standalone population where everything's done fee for service. Every service you receive, your provider bills for it and receives a payment. So it's very analogous to what we see with SeniorCare as well. But not only do we have these data sources from both the state and the federal government, we also use other data sources depending on the analyses. So we were looking at stuff related to income and financial assets and things like that. So we use data from the US Census Bureau. We're planning to use data from the Wisconsin Immunization Registry, although there's been some challenges with getting data access and things like that. But that allows us to do a really comprehensive look at older adults' vaccine history and how they receive their vaccines. And we're using data from the Pharmacy Quality Alliance to look at things like the quality of medication use, plans to use HEDIS measures, if you're familiar with those, again, looking at healthcare quality, et cetera, et cetera. So really a rich set of data, again, that normally in our research, we're not really able to get access to all of these sources of data. But because we're doing this for a very specific purpose, there's a need for this. For the states, on behalf of the federal government, that facilitates getting access to some of these things. So when it comes to enrollment and who's in the program and who's not, here we have some numbers from the first 4 years of the waiver period, looking at numbers of enrollees in those various groups. So the top row labeled enrollees is the total number of individuals in the SeniorCare program. So you can see they've increased a little bit over time to about 125,000 individuals right now in Wisconsin. But when it comes to what group do they fall into, what bucket do they fall into, you'll see that about 40% of them are in the waiver population and about 60% are in the non-waiver population. And there's some additional detail there about the specific subgroups within that. But you'll see that all of them are increasing except for the final one, which is sort of the proportion of waiver enrollees compared to the total enrollment. And the reason is, this is hint one, that SeniorCare is increasingly being used as supplemental coverage because the rate of increase in the non-waiver group, those individuals who have higher income, is increasing at a much faster rate than individuals who are in the waiver population. So even though everything's kind of increasing over time, we're seeing more and more that individuals with higher income are enrolling in the program. And again, they're not really impacted by the, but they are still receiving benefits through this program. Looking at the interaction between SeniorCare and Medicare, which sort of relates to the question earlier about people enrolling. So you'll see that hopefully you can see my mouse over here on the far right column. I'm going to go a little bit backwards here, because if you look at the typical population of older adults in the state of Wisconsin, about 70% of them enroll in Medicare Part D, and they have full year drug coverage through Medicare. Some of them have partial year coverage. So, if you turn 65 in October, well, you're not going to have full year Medicare coverage. You're going to have coverage from October to the end of December. And then hopefully the next year you'll have full year coverage. And there are some people who do not have coverage through the Medicare program. Again, this could be retiree benefits. If you're still working for an employer like you're at UW, then you would still be receiving benefits through your employer. But the vast majority of older adults in Wisconsin enroll in and receive full year drug coverage in Medicare. Now, if you go over here to the far left column, the SeniorCare waiver population, which is really our group of interest, you'll see that about a third of them are not enrolled in any sort of coverage whatsoever. So no other drug coverage other than SeniorCare. And another third do not have drug coverage, but they're enrolled in those managed care plans that typically do provide drug coverage. So I see a couple of you who I know have worked with Medicare data before, and you're probably like, what is going on here? This is really weird. I didn't even know there were Part C plans that provide this managed care benefit that didn't provide a drug benefit. Well, guess what? Here in Wisconsin, we have a really unique thing. Because we have the SeniorCare program, we found that there are a large number of older adults in Wisconsin who are either being really savvy in finding plans that meet their needs without having to double pay for Medicare coverage, or what we suspect is happening is a lot of these seniors are receiving guidance from places like aging and disability resource centers or other aging agencies in the state to help them identify these things. Because again, we didn't even know they existed, because if you look in the typical sort of Medicare population, in Wisconsin, only about 2% of people are enrolled in a managed care plan with no drug coverage versus 35% of SeniorCare. And we, at first we thought this was an error, and we spent a lot of time looking into this, and it turns out it's something new and unique that we didn't really know existed. So, but I mentioned the fact that some people do have coverage in the Medicare program, and you can see that about 20% of SeniorCare waiver members also have full year coverage through the Medicare Part D program. So these are those people enrolled in multiple insurances for an entire year. And again, there's a population that has partial year coverage as well, whether that's because you just turned 65 or maybe you drop in and drop out of eligibility for things. But you can see they're kind of different trajectories, different patterns of enrollment on some really unexpected things. Yeah.
I'm trying to think through if employer coverage is possible.
For SeniorCare, yes, it is possible to be enrolled in an employer-sponsored insurance plan with SeniorCare as your backup plan. So like all other Medicaid programs, they're the payer of last resort. So what that means is if you work in a health facility or in this case, a pharmacy, you would bill their primary insurance first, which would be either Medicare Part D, or if they have like an employer-sponsored insurance plan. And so what happens is they submit a claim in their computer, it's automatically approved or rejected and whatnot. And it says, your copay is $300. Then that $300 goes to SeniorCare, or if you have Medicaid or any other supplemental coverage, and then they spit out the final amount covering some of that for you. So when it comes to an individual who's enrolled in SeniorCare, if they bill your Medicare Part D plan first and they say your copay is $300, then it gets run through SeniorCare and the individual only has to pay the $5 or $15 copay, depending on the type of drug and whether or not they've met their deductible and stuff like that. So it does get confusing very quickly. I mean, this is something that I spent the last 10 years learning all the nuances of multiple insurances and billing and stuff like that. But the key point is that SeniorCare is the payer of last resort, just like Medicaid would be. So if you have Medicaid and Medicare, Medicare would pay first, Medicaid's always last. And you will find oddball individuals who have 3 or 4 insurance plans. It's very uncommon, but as having worked in a pharmacy before, so I have a pharmacy degree in addition to my PhD, it gets really confusing and it becomes a real pain to try and figure out what's the actual order you bill in to make sure things work. You get all sorts of errors and again, making sure that at the end of the day that the prescription drugs are covered and that people are receiving what they need. So just to give you sort of a broad overview of some of the findings from this report, again, these are just some high level things. You'll see our second sign that SeniorCare is increasingly being used as supplemental drug coverage is you'll see there were large decreases in the number of brand name drug claims and generic drug claims from 2019 to 2022. So again, those first 4 years. What that means is we're seeing enrollment increase, but use of the benefit is decreasing. One other explanation for this, if you've done work in the Medicaid space, is that during the public health emergency, they froze disenrollments from Medicaid, which was released within the past year and led to a lot of people kicked off of traditional Medicaid. We haven't seen that yet because of the annual enrollment within SeniorCare, so it's going to be a little bit more delayed than Medicaid, which is more like monthly eligibility. But so more and more people were enrolling or staying on the benefit, but use of the benefit was decreasing. But despite the fact we saw pretty large decreases in use of the benefit, you'll see that certain drugs are getting more and more expensive. And this is a reflection of those conversations happening at the national level around how expensive brand name drugs are getting. I'll talk briefly on the next slide about what are known as specialty drugs. So these are really, really expensive drugs. They're often very complex. Often instead of just being a simple chemical tablet, it's more, it has to be grown in an animal or a fungus or whatever. A lot more of them are injectables or more complex delivery systems, your Ozempics of the world, right? And they require a lot more clinical monitoring. There could be safety issues with these. So the short version is they're really, really expensive. And again, you can see we've seen an increase in specialty claims and a decrease in non-specialty claims. So more and more, SeniorCare is being used a little more specifically to cover these really expensive specialty medications. Medicare has definitions of what they consider to be a specialty medication. It increases every year. I think it's somewhere in the $700 a month range. If the drug costs more than $700, it's considered a specialty drug. Some of these drugs cost as much as $100,000 to $1 million or more. So these get really, really expensive really fast, which is why you'll see brand name drugs are getting a lot more expensive, and increasingly, here's hint 3 that SeniorCare is being used as a supplement, is I think it's somewhat being targeted for the use of specialty drugs. Because again, if you have a Medicare Part D plan, your out-of-pocket costs, even after your insurance covers it, could be thousands of dollars. I'd rather pay $15 than thousands of dollars, right? So I think there is some selection going on where people are strategically using this benefit to supplement what they're receiving from other sources of coverage like Medicare Part D. So one is how much are the drugs being used and sort of this idea of trying to protect people's health, but also there is this goal of trying to protect people's finances. So we looked at high financial burden due to prescription drug costs. We define this as the proportion of how much you spend on prescription drugs to your household income. And you can see that the rate of high financial burden is very rare, not just in the SeniorCare population, but also even in the Part D non-low income subsidy population. It's a different story in the low income subsidy population. Many of them do receive their drugs with little or no costs. But again, given how low their income is, how many limited assets they have, financial burden is much easier to accomplish in that group. Because if you have no income or assets and you have any expenses for drugs, you're gonna shoot up and be a bit of an outlier. But so about 2% of senior care members spend more than 5% of their income on drugs, very low, about half of what it is in sort of the general Medicare population. There are some factors that we looked at that are associated with a higher likelihood of burden. And some of this makes sense, right? If you're younger, but you have a lot of chronic conditions, odds are you're probably in a worse health state. You're probably using more prescription drugs. So you're probably more likely to have a higher need for drugs, higher out-of-pocket spending, things like that. But so from this, we think, yes, the senior care is meeting its goal to protect the finances of older adults enrolled in the program. I mentioned one of the other hypotheses and research questions were related to the quality of medication use. And one of the ways that we looked at this had to do with adherence to prescription drugs for chronic conditions. We took two different approaches of how we wanted to look at this. The first, so the top row for each, is looking at sort of the mean, what's known as proportion of days covered. So, in a full year, in a full calendar year, how many days out of 100% did you have your drug available on hand? We recognize there's some limitations. Just because you have it in your house doesn't mean you remember to take it. I know I've been guilty of that. And I'm, not taking as many medications as certainly some of these older adults are. But, you'll see that on average, regardless of which measure you're looking at, about the average adherence rate was about 90%, which means about 90% of the time people had their drugs available to take as prescribed, which is good, right? We want to make sure that's as close to 100% as possible. The other way to look at this is are you adherent, yes or no? And a typical cutoff that's used in the literature is 80%. So again, we use these data came from the Pharmacy Quality Alliance, and they're the ones who set up these cutoffs and things like that. These are the same quality measures that are used in the federal Medicare program to rate and assign star ratings to Part D plans and Part C plans. And so this is how many people in your population are adherent or have an adherence above 80%. You can see the numbers are a little bit lower, so there's some room for improvement here. So it's around 80% of people had their medication available 80% of the time or more. So yes, we would flag them as adherent, but a little bit lower and obviously some room for improvement. But again, pretty consistent regardless of which disease state we're looking at. And certainly there's other medication classes that I'm not showing here. But again, sort of telling a pretty consistent story. Medication adherence was consistently high regardless of which medication classes we looked at. I mentioned the other dimension of this is looking at medication safety. Now we want these numbers to be as close to 0 as possible. And so, you can look at these measures and see less than 10% of people are using sort of what we would maybe consider dangerous or unsafe medications, or maybe medications that maybe we don't expect it to be completely 0. There may be a legitimate reason why someone may need these medications, but we would like to see them as low as possible. And so some of these measures are incredibly low, almost 0.0%. But, we're seeing, generally speaking, that dangerous medication use is uncommon. This is just in the waiver population because they're who we're most interested in. And generally speaking, based on the results from the medication adherence analysis and the medication safety analysis, it does seem like the program is meeting its goals to support member drug use safety and quality, although there may still be some room for improvements. We also compared health status, and some of this, I think, is helpful to understand how is the senior care population similar to or different from Medicare beneficiaries, or sort of those LIS and non-LIS enrollees. We measured health status in 2 different ways. One is using an existing measure known as the Charlson Comorbidity Index. So this is looking at a series of conditions that predict someone's likelihood of mortality or dying. We also, the Medicare CCW data has a chronic conditions file where they just have sort of a list of priority chronic conditions. So that was another way that we looked at this. And what we found is that essentially senior care is kind of in between the two. They're significantly healthier than the LIS population. Again, that makes sense. That's typically composed of people with incredibly high health needs. Maybe they're disabled because they have so many health needs, and so they have very low income. But they're often a little bit sicker than the non-LAS population. So they're kind of in between. Again, if you look at the interaction between the different groups, some of those waiver and non-waiver subgroups vary, but generally speaking, they're kind of in the middle. And if we look at certain types of chronic conditions, the prevalence of those conditions are again similar between senior care and the non-LAS population, which is why I think they're the best analogy. But if you look at things like really severe illnesses, just as an example, dementia, it's 3 to 4 times higher in the LAS population. So again, there even in the Part D population, there's separation between individuals with really, really high health needs in that LAS group. And generally the non-LAS population is more healthy. Looking at the use of healthcare services, I mentioned one of the goals of the program is to keep people from spending money in other areas of health, spend less money on drugs so you can save money elsewhere. And so we focused first on inpatient hospital stays and emergency department visits, since these are often things that could cost hundreds of thousands, if not millions of dollars, depending on how long you're there and what you're there for. So we used the data from that Medicare CCW data to be able to look at how was the patterns of use for these types of services for senior care members compared to the Part D population. And similar to the previous analysis, senior care is kind of in the middle, right? Which makes sense. There's a correlation here that their health status is kind of in between the two. They had fairly similar patterns in terms of how many times did they end up in an emergency department, or how many times were they admitted to the hospital, length of stay, the cost of those stays, and so on. But definitely their use of these services was much less than the low-income subsidy population. And so further work in this area right now, we're working with the outpatient visits. We started with the really high cost, much rarer ones, because those are really an area of focus. But most people don't really end up in an emergency department or a hospital in the course of a year. So looking at the outpatient visits, it's a little bit more of a lift because there's a lot more of those, right? An older adult may be seeing multiple providers, they may have multiple visits per year, and so that's going to be a bit of a heavier lift. In terms of vaccines, so coverage for vaccines began on June 6th in 2022, and we did see rapid uptake of this benefit by members. Interestingly, the majority of claims were for the shingles vaccine. Part of this aligned with changes to evidence-based guidelines that said, even if you had a shingles vaccine in the past, there's newer and better ones. So you should go out and receive vaccines again if you have received them. And if you haven't received them, you should receive vaccines. So those guidelines say you should get 2 doses within 6 months of each other. And so we did see, sort of looking at this from a quality perspective, that the majority of senior care members that received a first dose also received a second dose. So again, not just are they using the benefit, but they're using it in accordance with what we would expect for high quality use of the benefit. So we're going to be spending more time looking at the vaccines now that we're a little bit further out from when that came in. But again, another change was they added coverage for the RSV vaccine that was approved at the end of 2023. So again, we'll be able to look at that once we get those claims in future data pools. And this just graphically shows that, again, on the left, it's a little bit small, a little bit hard to see, apologies for that. You can see that there's this greenish blue, and the orange here are our waiver group on the right. So about half of the vaccine claims were for the waiver population, and the other half were for the non-waiver group. But overwhelmingly, about 85% of claims were for the shingles vaccine, again, sort of triggered by changes to recommendations. But again, it does show that the program's being used. And there are some other types of vaccines we saw claims for, including the tetanus, diphtheria, and pertussis vaccine, and COVID-19, as well as some others. So we're hoping to see some RSV uptake as well. The final thing I just want to present on, and then I'm happy to open things up for more questions. It's incredibly rare for senior care members to end up in receiving full Medicaid benefits, which again is a good thing. That's what we wanted to see. And if we look at nursing home admissions, about 1% of individuals were ever enrolled in senior care. So we went into the archives and looked all the way back, and we looked forward to see, did they ever end up receiving a nursing home admission that was paid for by Medicaid? And very, very rare, which is good. Again, we don't want to see that. And those individuals that did end up in the nursing home, again, it's no surprise. It's typically people who were older and sicker, had higher health needs. But interestingly, when they entered the nursing home, they were often healthier on average than sort of the typical Medicaid population that entered. So again, it does seem to be meeting that goal of protecting their health and keeping them out of nursing homes and out of the Medicaid program. So thinking of the implications of this for policy, again, I think some of the evidence I showed today, I hope shows that the senior care program appears to be meeting its stated goals and meeting the needs of its members. We did see increasing enrollment over time, although we are, again, increasingly seeing it used as a supplement. So we did see a decrease in claims, but it is preventing medication-related financial burden. It does seem to be promoting medication use safety and quality, which we like to see. And there's very, very low rates of nursing home admissions. So those are the positive things that we're seeing out of the senior care program. But certainly we need to talk about some areas for improvement. I mentioned the idea that brand name drugs, specifically those super expensive specialty drugs, are increasingly becoming a problem. That's not unique to senior care. That's a problem being faced nationwide. Again, that's why we had the Inflation Reduction Act in part and other policy discussions around how we can control costs for the Medicare program and other programs. There's some further opportunities to improve some of the medication use safety and quality measures. Generally, they were very high. I don't want to discount that. Some of them were a little bit lower than the general non-LAS population, which shows that there's potentially some room for improvement there. And one way to do that could be the fact that there was this really low uptake and provision of that MTM, the medication therapy management benefit, where really you'd have that opportunity to talk with a pharmacist, have that comprehensive medication review, look for more cost-effective alternatives to help address the use of specialty drugs and brand name drugs. You know, are you paying for a drug that there's something cheaper available that does the same thing or something very similar, or that may be safer or more effective for you? And are there opportunities to talk with older adults about the potential dangers of taking certain medications or combinations of medications? And since that is an essential Part D benefit, this was something we really highlighted in that report, and that DHS has been very receptive to overhauling that part of the benefit. But shown here are some of the main players in the senior care evaluation team. Dr. Namyo Kim is a scientist working with me and helping manage the day-to-day of this. Aaron Wynn's an associate professor at UIC. Really has a rich background in a lot of different areas, especially in the econometrics. Tim Connor, unfortunately, wasn't able to be here today, but he's the MRTA program manager. I also want to make sure I recognize Sohee Kim, who's a graduate student, PA, working with us on the project. Krista Brisgornia and Brad Nelson, I see, is in the room from the data science team. So thank you for your help and support. And then we've also had a lot of support from the Wisconsin Department of Health Services, including people like Stephanie Riley, Appleby, and Susan Sieber. And I think we've been working together about 7 or 8 years now, and we have a pretty good working relationship. And again, I think this has been a very beneficial relationship through this MRTA arrangement to help support the research that we're doing here at UW, give us access to data and other things that help support what we do as researchers, while also helping the state meet the needs of older adults in our state. So thank you very much, and I'm happy to open things up for Q&A.
A little bit about politics program in 2020, looking at current labor requires. Will it need a new IRP? Is it continue or push back against state funding of this?
Great question. So the politics of this, luckily they're much simpler and more straightforward than the Badger Care ones. I would not recommend asking Dr. Burns about the politics of the Medicaid evaluations, but senior care has been very positive regardless of administration. So I believe this was renewed under Walker's administration. It was renewed before then every 2 to 3 years. So Democrat, Republican majority, it was very positive. So that has helped that there's been legislative support for it and continued funding from the state level. And they've been very successful at renewing the program over the 20 odd years that they've been in operation. It's a little bit early still, but even though they only have, only 4 years left, they are already thinking about what sort of information would we need to inform a renewal? That's informing what we're doing as an evaluation team to help support, again, looking at what the needs are of the older adults. What is the program meeting? What is it not meeting? So that if there are any changes to the structure of the program, they can use that to improve the program and submit for continued renewal. So I think there's a high likelihood of renewal if they choose to go that route. And again, it's remained very stable over time. I think that comes with some risks and some benefits. You know, I think there are some opportunities to change things, but if you have a waiver in place for 10 years, it doesn't really promote rapid change to things as well, right? So it does promote stability, but it doesn't necessarily prevent quickly addressing some of these problems. But generally speaking, politics have not been a significant barrier in this program like they have been in other programs like the Medicaid.
Could you talk a little bit about how to think about these findings in the context of COVID and what that might have done to the population of elderly who were?
Yeah, so COVID, like I mentioned, one of the big impacts of COVID had to do with changes to enrollment and disenrollment, where just like in the Medicaid program, they essentially halted kicking people off. So even though you were only supposed to be on for a 12-month period, they kept them on without having to pay the renewal fee, which is similar to what they did in the Medicaid program as well. So that's why I think we're seeing these increasing trends over time, less use of it because people are like, well, I thought I didn't have it anymore, or, you know, I don't need it anymore, but they're still, you know, they were never from it. So some of our analyses, we focused on just users of the benefit rather than the whole population.
Ask my question differently.
Yeah.
Should I be worried that sick old people died disproportionately during the pandemic and that changes in what types of drugs are being purchased reflect that?
Yeah, so I mean, I think I would say yes, sick old people did die. Personally, I would say, luckily for this program, I don't think that's their main population. I think that would probably disproportionately affect maybe like that low income subsidy group where, you know, these may be people who are more likely to be permanently institutionalized in nursing homes, stuff like that. So I don't think it necessarily had a big impact on mortality, but we have not specifically looked at it because we don't have a great way to do it systematically. I mean, certainly there's the mortality data here. There is a flag in the Medicare data of whether someone died or not as well. But we know there's some limitations with those. So I just don't think it's as big of a problem, again, in part because of the characteristics of the population. But we did see some other changes that occurred more programmatic in nature that I didn't talk about. So a lot more people in the pandemic switched to mail order pharmacies, right? They stopped going in person. They started covering 3-month supplies more frequently. So, you know, the number of claims decreased, but actually if you look at it on a like claims per 30 days basis, more and more of those claims were for 90-day supplies instead of 30. So you kind of have to double or triple some of the numbers. So when you look at it on a sort of normalized basis, it brings it up a little bit more, but still not quite as high where it still was going down. But there's changes in the way that they made some changes to the program to make things easier during the public health emergency. Some of those stuck around, some went away. But again, it didn't have a huge impact on senior care necessarily, but certainly that's sort of, hopefully we're getting to the point where we can start just excluding those years of data from analysis because they're so different than before and after the pandemic. But unfortunately, that's like smack in the first 2 years of our evaluation and certainly led to, I think it took us 2 years to get the Medicare data in-house from when we applied. Because we sent in our application and then they shut down like year. So, you know, it took them a year to actually review it. And then like I mentioned, there's a lot of challenges in sending social security numbers and getting state agency approvals to do that and things like that. So there were a lot of delays in getting those data as well. But, you know, now that I can sleep a good night's sleep, knowing that we have the data and everything's in-house, I can relax now. That was certainly successful.
How should we think about the increased proportion of the higher income group using senior care and how that might influence positive outcomes? And also, is senior care reaching the people that should be getting it, or is it the people who know how to work a system?
So that's a great question. I think that really is something that we have struggled with and tried to outline in the report as well of is senior care meeting the populations that it needs to reach? And is it really being used in the way that maybe they intend it to? I think from the state's perspective, you can kind of view them separately and actually be focused mostly, I believe most of my results were just in the waiver group, because that's really who CMS cares about. That's who they're paying for. So from the state's perspective, they're helping to pay for both, but one population is just cheaper for them to cover. They could end the non-waiver group and still receive these matching benefits and stuff like that. So I think that is maybe where the question is in that non-waiver group. But on the, are you reaching the intended population? I mean, if you look at some of the demographics of the population, the waiver group is like, 99% white, 65 to 75% women. Like, it's not reflective of the general population of older adults in the state of Wisconsin. So whether people are receiving equal information, or are they being guided in the same way, or is there just not enough outreach? We actually had a conversation with them last week about this, and they said that was an area they had received feedback on from members, was there needed to be more outreach, more awareness of program changes, of benefit changes and stuff like that. But I do think there's room for improvement in that and making sure they are reaching that's eligible. We also noticed, interestingly, that there were more rural individuals enrolled in the program. And more anecdotally, again, these aging and disability resource centers, or these departments of aging that are in each county or in groups of counties, I do think there are hubs in the state who are really actively encouraging everyone and their mother, really everyone and their mother, to enroll in the program, because, hey, it's $30. If you don't use it, who cares? But if you need it, it's there as sort of a safety net. So I think there are some geographic variations in that as well, where we're seeing a lot more than average of a rural population enrolling in this. So I don't think seniors are necessarily doing this on their own in isolation. I'm frankly not savvy enough to find some of these plans that they're enrolling in to sort of be cost effective in how they're enrolling. So I do think there are some agencies that are providing that support. We just don't have systematic evidence right now of who's doing that and how are they doing that. I think that's something we can look into more.
Yeah, a couple questions. So based on your discussions with DHS about how they might want to change the program in the future, as you noted, it may be not imminent because
Maybe not.
Yeah, maybe or maybe not. But just I guess in two respects. One is the MTM. I thought that was a really interesting finding that they have to offer it, but the uptake is so low, even though polypharmacy is probably substantial in a older population. Is that something that they could require if some trigger, if you're on X number of drugs, you need to have an MTM? And then on the other hand, is that something you
Can I answer that one first?
Sure, yeah.
Before I forget? I always hate the multiple questions because then I'm like, okay, I remember the first one. So just to clarify, it is a requirement of Part D plans, but SeniorCare doesn't have the same required criteria. So they don't technically, since they're considered creditable coverage, they don't have to follow exactly what Medicare Part D requires. That is a recommendation that we made to them, though, is have clear criteria of who's eligible, so that the pharmacists or the patients themselves or the administrators at SeniorCare can say, again, the typical criteria in Medicare Part D are you're taking more than 3 or 5 medications, you're spending more than $2,000 a year on prescription drugs, or you have a certain number of chronic health conditions. So, I mean, why reinvent the wheel? You could just sort of take those guidelines from Part D and use them in SeniorCare, and that was something we encouraged. But one thing we found as a result of this is essentially the provider network that they had set up exclusively to offer those services is essentially dissolved. And so they're sort of at a point where they need to create a new network or identify new providers to offer those services. So they're at a good point to be able to make those changes to enhance that part of the benefit. And that won't necessarily massively change the program, right? It's just trying to improve that one piece. So part 2.
Okay, and then my other question was, this very easy application process seems so different from every other safety net program. So I'm just wondering if that's something that's come up on the political side, or if you're thinking of changing that at all.
It hasn't come up on the sort of as a negative. I don't know the level of rigor that they use to sort of double check or verify numbers. I think there is, to an extent, some honor system in employment here. And since that information is only collected once a year, your income could increase right after you apply, and and you'd still be eligible at that one level for the next 12 months. But the main way that we're hearing it is a positive in terms of administrative burden and sort of those discussions that they've had in other state programs where page after page after page and stuff like that. They do, I believe, try to do a basic screening for Medicaid eligibility, but there's no formal screening for Medicaid eligibility, not like the healthcare.gov marketplaces and stuff like that, where they sort of have a process in place to see you might be eligible for Medicaid. SeniorCare doesn't. It's again, it's very informal. It's much simpler, and they don't really collect the same kind of information. So I think they even say on the application, like, this is not a screening for Medicaid eligibility. But again, I haven't heard of it in a negative way. I've heard of it in a positive way.
Thanks.
Jeff, you get the last question.
Oh, save the best for last.
I was interested in the no asset test aspect of this. So Bucky's Tuition Promise, which offers free tuition and fees to low income people in Wisconsin students, also is different from other state programs that do similar things because it has no asset test. And it is justified in that context, as in this context, as a reduction in administrative burden. But the fact of the matter is, if you look at the data, there's people where you go, well, they have a lot of assets. And so that's leads into a question of, there's sort of two ways that this SeniorCare can keep people off Medicaid. One way is by improving their health, and the other way is by preserving their assets. So they're not eligible for Medicaid. Do you have a sense of sort of which those two it is, and why haven't there been newspaper stories about why are we paying for drugs for these rich people?
That's a good question. Honestly, I think there's a lot of self-selection into this, coming back to are the people who need it being enrolled in it, and is it being used appropriately? I certainly don't want to phrase it as like it's being abused in certain ways. I think we have seen some signs, again, of some selection of, like, maybe people with expensive specialty drugs are disproportionately being referred to this program as a way to save money. So I don't necessarily think it's being abused that way. I think it's just that if you're, we're seeing more people sort of like more in the middle income range who are enrolling in the program as a backup. And so they have less of a need for it, or they're just not using as many drugs. And so some of these people could save money by switching over to Medicare, even with a monthly premium and all that stuff. We have not yet done, we would, in the next couple of years, we would like to do more research into sort of the utility of SeniorCare enrollment versus Medicare enrollment versus Medicaid, and sort of seeing, is this the right program for all these people, or are there maybe better alternatives? Either you're in SeniorCare and you should be in Part D, or vice versa. But I don't know that there's necessarily been strategic gaming of that, except, again, some of these signs that maybe some people who have really high drug costs and are already in Medicare, you complain to someone and they say, oh, well, hey, you should enroll in this other program because then you only have to pay $15 a month. So I don't know that it's necessarily, we're using this to hide our assets. We're using this as a loophole. And actually that lowest income population really is a very small number of people. I think it's less than 10% of the enrollee population. So more people are a little bit further away from, like, Medicaid eligibility, dual eligibility, low income subsidy, and stuff like that. So there aren't that many borderline people who, I think it would mainly be if you tried to apply for low income subsidy or traditional Medicaid and got rejected, this could be a backup option.
Yes.
Thank you.